please come over closer to me. Excellent. Thank you. And a little bit further. Yeah, thank you very much. So, we're just going to start off. I'm going to start off a transit dominating examination first thing. So I'm going to start off the TRqədC. And I'm selecting TRqədC, do a routine preset. And as I do the routine preset, scan down from inferior, which is the very bottom, the speech presentation, which is efficient because I'm not going to be able to do it on the scan. And the data has to be phallic to do it on the scan. And so looking at here, start off the head of the fundus of the uterus. And then as I sweep from the left side to the right side, and I confirm that there's a single baby on board. And this is a 4 changes with the heart. So that's the first thing that I do, my single sweep to the baby. And now I'm going to magnify the inch, and I do so by reducing my depth. I'm then going to put that on sector width. And then I'm going to head up to the evaluation of the fetal brain. As I come down to the evaluation of the fetal brain, I'm just going to, number 1, just increase my acoustic output. Number 2, I'm going to slightly increase my gain. And number 3, I'm just going to magnify the image. Everything to do with ultrasound imaging is important to magnify the image. As I look at this baby's brain, I'm going to start off by taking a view through looking at the sulcations and gyrations of the brain. So the first thing I do is I look at the midline phallus, and I compare at a very high level. I look at the size of the hemispheres on each side and see if there's any signs that suggest any negative impediment. And I see a slight discordance in the size, where this side of the brain is slightly larger than this. If you ever see something where there's a discordance in the size of the ventricles, you need to consider migration of brain disorder. So that's the first image that I say. The next one, I'm looking at the sulcations, gyrations. You must remember that the babies at 24 weeks, at this stage, we not expect to see many sulcations and gyrations. We just observe sulcations and gyrations here, and sulcations and gyrations here. I also look to see if there's any increase in the interhemispheric distance, because if I see that there's an increase in this distance, this is the medial wall of the hemisphere of this side, this is the medial wall of the hemisphere of this side. If the distance between the hemispheres is increased, this is a marker for agenesis of the corpus callosum. So I will say in a minute of that as well. The next, according to the SIêU guidelines, is I need to bring the cadence septum pellucidum into view. So as I come down, I look at the cadence septum pellucidum, and I have here, I can't see the typical cadence septum pellucidum, but I can see some fluid just here. But it's not the typical CST that I would expect to see at 24 weeks. I would expect to see a clearer box of fluid. At the level of the cerebral lateral ventricle, I want to measure, because this is the next section down, I want to measure the size of the cerebral lateral ventricle. So I take down my magnification, I bring the walls of the lateral ventricles into view. For this, I'm going to augment to get a little bit more penetration. And when I get the walls of the lateral ventricles into view, I need to bring my CST in at the same level. So when you are measuring the sections for the SIêU guidelines, you always have the CST in view for the transventricular, transthalamic, and transcerebellar measurement. So I take a measurement of the inner wall to the inner wall on the opposite side, and you take a measurement at the level of the globus of the choroid. That's where you measure the lateral ventricle. And you save that image in the single image file. The next measurement that I come down is taking the measurement of the thalamus. So the thalamus, I expect to see the acrovertebral sylvius. I'm looking between the mesencephalon, which is just here, to the acrovertebral sylvius. And this here is the fluid space, is the cerebral third ventricle. So again, I need to try and get my cadence septum pellucidum into view to measure these structures. when I'm looking at this here, I'm asking myself the question, is the third ventricle enlarged? So this is to me, it's okay. As I look at the third ventricle, I bring down the size of the third ventricle, and that's the third ventricle in view here. This here is the cerebral peduncles, as I bring it to view here, also called the mesencephalon, and this here is the thalamus. The more echogenic structure that lies anterior to here is the caudate nucleus. So we mark this here, but this here is the caudate nucleus. And then we can see from this point here, we can appreciate the midline flaps, which goes back to here. This is the pericallosal sulcus, which goes to here, and the pericallosal sulcus on the opposite side. This is referred to as the anchor ANCHOR complex. It's also called the anterior complex. It's an important view to take in terms of the exclusion of agency of the corpus callosum, or evaluation of the corpus callosum and the pericallosal sulcus. So the anterior complex. So this is the second level taken at the level of the BBB. We also look at the Sylvian fissure. When you get to 24 weeks of gestation, you expect the Sylvian fissure to be at right angles. The angle of this Sylvian fissure is the order of about 45 degrees. So if we draw a line from here, and draw a line from here, you can see that this angle here is about 45 degrees. At 24 weeks, you would expect this to be more straight, but I have not looked at it in all plane. I'm just looking at the level of the BBB. So I save that image to the file. This is the second section of evaluating the fetal brain. And I clear the text, and I go to the final section of examining the brain, and this is to look at the cerebellum. As I come down to the cerebellum, again try to bring the cadence septum pellucidum into view. And again, I can see the fluid just here is the cadence septum. This structure on either side is the fornicate. This is the fornicate on the near side. So this is the fornicate on the near side, just here. And this is the fornicate on the far side here. And between here is your cadence septum. This here is your anterior horn of your lateral ventricle, and this is the anterior horn of the lateral ventricle on the far side. As I am looking at this transcerebellar view, I'm seeing that there's a communication between the fourth ventricle and the cisterna magna. So I need to examine this in more detail. So my next step is to come down and take a measurement of the transcerebellar diameter. So in this view here, take a calculation, second trimester, transcerebellar diameter. And I measure from the outer border of the cerebellum to the outer border on the opposite side. And in this view, I also take a measurement of the cisterna magna that looks increased. And that's the measure of the cisterna magna. The upper limit of the cisterna magna is 10 millimeters. As I clear over the data on the screen and back to looking in more detail at the posterior cranial fossa, because I want to see more detail, I want to see the cerebellar hemispheres. I want to compare the cerebellar hemispheres on the left-hand side to the cerebellar hemispheres on the right. When I'm up the head cerebellar hemispheres, and I see the fourth ventricle and the communication, I'm going to increase my gain. I cannot do a transvaginal scan with sagittal imaging because the baby is in breech presentation. I can see if I'm trying to turn the baby or ask the mom to go to the wall in the hope that it's not turning. When I look at the cerebellar hemispheres, I'm looking to check that the size of the cerebellar hemispheres, generic, area, trace. I'm looking to see that the size of the cerebellar hemispheres on each side are similar. So as I come across here, I check the cerebellar on this side. I don't measure the area, but I subjectively look at my eye just to make sure that the area of the cerebellar hemisphere on each side is the same. I want to make sure that there's no asymmetry of the cerebellar hemisphere. Sometimes you can have a arachnoid cyst, sometimes you can have posterior cranial fossa anomalies, you can have a telephone receiver-like appearance, which we had in the TU hospital just the day before yesterday. So as you come across on this page, the next step is to then take a 3D volume. So I select 3D, I select the quality for max. I'm going to open my volume, and then the angle I'm going to increase to 80 degrees. And once in this position, I'm going to say stop breathing. And then I count down. 5, 4, 3, 2, 1. So the next thing that I want to do is I want to look at the firmness of the baby frame, because the sternum magna is increased. When I look at my volume, before I analyze it, I look at the B plane to see whether there are any motion artifacts. And it looks okay to me as I look at that. I go on to do a render of the posterior cranial fossa. I want to do multiplanar. And in terms of the multiplanar evaluation of the brain, there are a number of ways of doing it. The first way is called the Z-axis technique. You can see my hand. So this is the Z button. And I select the A plane, and I place the reference dot in the middle of the face. And then I hit the Z button, and then I rotate until the head is in a 3 o'clock to 9 o'clock position. And then I do the same on the next plane. I select the B plane, I put the reference dot in the middle of the face, and I rotate the brain until I get the brain into a transverse position on the right hand side. And then I select the C plane, and I magnify the image of the C plane, and then I rotate on the Z axis on the C plane, just looking at the vermis. And when I look at the vermis, I'm looking at here the outline of the vermis, which I can then change to here. And as I look at this here, I'm looking for the contour of the cerebellar vermis. But this is not the way I like to do it. I prefer to take the A plane and to manipulate the A plane. So let me show you. Because I know exactly where I'm going. So I select the A plane, and I go full screen on the A plane. And then I hit Z, Y, X. So the first thing is I magnify the A plane, and then I translate through the volume of the A plane, looking at my cerebellum. I then do a Z-axis rotation. And now what I have on view is I have a cerebellar junction here, cerebellar hemisphere here, and the cerebellar hemisphere here. I then place my reference dot in the fourth ventricle. And this tissue here is the vermis of the cerebellum. And I want to know whether the vermis is normally formed. Because I want to know, am I looking at late type cyst, or am I looking at a double wall malformation? So once I've manipulated the volume, the next step, having done a Z-axis rotation, and then remove the reference dot, and then do a Y-axis rotation. And as I turn around the Y-axis rotation, I now get my view of the cerebellar vermis. As I look at this baby's posterior cranial fossa, I can see the communication between the fourth ventricle, which is here, and this is the pons and medulla, and this here is the cisterna magna. I can appreciate that I have a communication here between the fourth and the cisterna magna. I now magnify the image up, showing this. As I clear this image, I can then measure the generic angle, and I can measure the Vernian angle. And as I do so, I have an angle that's 32 degrees. So in an angle that's at 32 degrees is more in keeping with the Blake's parish than it is with David Walker. Up to 20, you accept it being normal. From 20 to 40 to 45, you accept it being Blake's. And then more than 40, you would consider it being David Walker. When I look at the vermis, I then have to ask myself, is the vermis morphology normal? My problem is I much prefer to look at the vermis morphology at transvaginal volume acquisition, because the transabdominal reconstruction is not as clear. But still, I can measure the height, I can measure the anterior posterior diameter, and I can then measure the generic area. This here is the fastigial point, and then I measure it from around, measure the area trace, I measure the area of the vermis. I don't carry the chart in my head, but I will need to pull out the chart and work out for 24 weeks of gestation whether the area of the vermis is okay. I then save this volume to the drive. When I'm looking at this, I can then look from the left cerebral hemisphere to the right cerebral hemisphere. So we focus up here on this plane, I need to do a Z-axis rotation just to make sure that I'm actually getting a correct view through the full cerebellum from left to right. I can then also increase the distance, so I'm examining from the right cerebral hemisphere to the left cerebral hemisphere. And you can go from here, you can see the cerebellum hemisphere here, to the vermis in the midline here, to the brainstem here, and then go across to the cerebellum hemisphere on the opposite side. This is a tomographic ultrasound slice, the same day. And I'll save that image to file. The other thing which I can do is I can change my slice thickness. So my slice thickness, I use 1 millimeter for the first semester, 2 millimeters for the second semester, and 3 millimeters for the third semester. This is my first volume of acquisition, and I would like to see whether I can improve on getting a better view of the post-cranial process. I'm still seeing a slight discordance in the cerebellar hemisphere because I think that the cerebellum is just very, very slightly rotated. So anytime I see any slight rotation of vermis, I always ask myself the question, is there any evidence of an arachnoid cyst? Now you can see on 2D that communication between the third and fourth subregion. So I think this volume is a little bit better than the last volume. Again, we start off with multiplanar. I'm going to bring my volume spectral reduction imaging down a little bit. I'm going to take my BCI off. I'm going to select my A plane. I'm going to rotate around my A plane. And there's a reference dot in the middle of where I expect the vermis to see. And then I'll rotate to just look through the plane that I've got. I think I've got a better view now of the cerebellar hemispheres on both sides. And as I do that, then I rotate through the volume just to look at the rest of the body of the baby. So the cerebellar hemispheres to me are normal. I cannot see any reduction on either side. Once I get to here, I see the ridges of the cerebellum on the side here, which looks normal form. And then as I come across that, then I can rotate on the y-axis. And now I get a view of the vermis of the cerebellum. As I look at the vermis of the cerebellum, I'm looking to see, can I see the foliation of the vermis of the cerebellum? And again, I'm not going to go back and measure, take all my measurements again, but I'll go to BCI. When I turn down the gain very slightly on this baby, I can see within this that I can see the individual portions of foliation of the vermis. Please remember that I'm not going to get as good detail that I would get with a giant scan in a 3D volume acquisition. But enough to say to me that when I look at this, I see there is some anterior compression of the vermis, but to me the height of the vermis is normal, and so does the area. But again, I would correlate this finding with the finding of an MRI. When I look at the rest of the baby, I want to look at the anatomy of the rest. I'm going to change my 3D transducer. I'm now going to move to a 2 to 9. So in a 2 to 9, I'm going to go to the routine preset, and I want to start looking through the fissures, Sylvian fissure. I want to look at the cryocytical fissure, and I want to look at the singular gyrus. So let's start. So we want to look at the rest of the brain anatomy. And I'll see also if I can try and get the baby inside of the section, which we were trying to say. Let me finish with axial evaluation. So as I come across in the axial evaluation, I'm going to move to TRedd HD7, which is a very high frequency 7. And I want to look at any signs of cytomegalovirus infection. So if I come across, I'm looking at the junction between the thalmi and the powder nucleus. So this is the powder thalamic junction that's here. I'm looking to see if there's any evidence of any calcification. As I'm coming through here the posterior cranial fossa, I'm now looking through the posterior fontanelle. I want to see if I can get the corpus callosum, the posterior aspect of the corpus callosum. As I look at this here, I'm looking at the scene of the cerebral hemisphere. I'm looking to see the extra axial space with migrational brain disorders, you can either have increased sulfation gyration, which you have a large head, or a reduction in which you have presented with microcephaly. An important part of the evaluation, which I have not gone into this stage, is to take a DVD and head circumference. But that is something in the interest of time, I won't do that, but just something you will see. Microcephaly is one of the features of a migration brain disorder. When I'm looking at the Sylvian fissure, I'm looking at the Sylvian fissure and saying, is it at right angles? So if I come down and evaluate the Sylvian fissure, remember I said I expect the Sylvian fissure to be at 24 weeks of gestation. I expect the Sylvian fissure to be about 90 degrees. It is slightly less developed than I would expect, but again I will be dependent on an MR. It's a very borderline finding. The next I want to look at is the cryo-occipital fissure. So at this point here, I look at the level of the lateral ventricles, and I'm looking for outpouching coming out here to see the cryo-occipital. I'm going to move back to the arms to see both, because I think I'm going to get better resolution. You will note that every time I do a scan, I never scan with one probe. I always move between probes, because I believe that you can only find out what probe is best if you move between two probes. You just set up the one, you don't know if you have best resolution. Now let me come back and have a look at the sutures again. I'll just come back and have a look at that Sylvian. So if you look at that Sylvian image there, you say, Simon, that looks okay, because it's coming up at 90 degrees in that Sylvian fissure. Because at 24 weeks of gestation, that's exactly the right. But I can't see it coming down the opposite side. Should be, this is the shape of the Sylvian fissure that you would expect when you 4 weeks of gestation. But it's pretty close to it. It's pretty close. And with regard to the cisterna magna, you want to look at the cisterna magna and just want to see if is there any evidence of an arachnoid cyst. So I want to look at the posterior cranial fossa. I want to increase my gain. And I'm going to press open edge. And as I do so, I'm looking to see if there's a cyst in the posterior cranial fossa. So as I come through here, I can see the band, which to me looks like a base pouch with communication with the fourth ventricle with the base pouch cyst. It's important to look at the location of the choroids. It's Gary Paladini who's important of the location of the choroids and helping distinguish whether you're looking at base of David Walker, although there is controversy about the value of that in distinguishing differential diagnosis. This is back to looking at the aqueduct of Sylvius at this point here, and this here looking at the midline, you can see a fluid filled cystic structure, the cave vein is a positive, which is a normal anatomic variant. I think the third ventricle, as I look at the third ventricle here, interposed between the thalami on both sides, I think that is normal. When I come around at this level of the ankle complex anteriorly, I look to see here, this is the region that I would expect to see the singular gyres, which is a tiny gyre that comes out on either side. But again, a transabdominal examination, that is going to be hard to see. So my next step, having gone through all the axial sections, is then to move down to the Bailey's face. So coming down to the Bailey's face, and down, every time I'm looking at any brain abnormality, it's again important to evaluate the face. As I look at the face, I come around to looking at the lower lips, the upper lip, the left nostril. I look at the eyelids are fused, not fused but closed. So this is the upper eyelid, the lower eyelid. And as I go through to the eyelid, I then can see the eyeball. As I magnify the image, I see the lower and upper eyelid, in this position here, lower eyelid, upper eyelid, and then through into the lens, making sure that there are no cataracs. I also look at the posterior aspect of the eye, looking at the retinal nerve to make sure that there's not any retinal nerve activated. This looks like a normal retinal nerve. As I come around posterior to the back, I look for any colobomas. As I look at the eye, I can see what looks like a normal eye appearance. As I come down to the baby's face, I look at the choanae, I look at the hard palate, I look at the mandible, and I check the nostrils on both sides. As I come up to the baby's profile, and now I'm trying to get the sagittal brain. to the sagittal brain, I need to try and push the baby into a position to get into the sagittal brain. So like that, come up. Can somebody please control the machine for me? Maybe increase HTZ. So I'm using both my hands to feed the baby brain. The first thing I see is the gene of the corpus callosum. So with the genome in view, I then rotate up the genome to bring the corpus callosum into view. Please put on paragraph. Slow. Thank you. And just turn the background, just increase the acoustic output. Thank you. And actually put the background on. And then just increase the output from 97 to 100. And then increase the gain of the circuit. So when I'm looking here, I'm trying to get an idea of the pericallosal artery. I can see the full length of the pericallosal artery, which is very helpful because I'm trying to work out whether this baby has got a genesis or not, because I'm having difficulty seeing the CSP should normally be a good sized structure that I cannot see here. But looking at, I can clearly see the genome of the corpus callosum, the body of the corpus callosum, and I can see, if I extend posteriorly, I can see the full length of the pericallosal artery, which brings me a degree of reassurance. Again, I'm going to go back, push the baby's face up, and let's want to take a quick profile, so I can have a profile of the baby. So as I magnify the image of the face, just take the weight off the transducer, see the symmetry of the orbits, and then I'll take 90 degrees. When I look at this point here, the required volume, I select volume max on an angle, stop reading. I check to see whether any evidence might be made here in a slight recession to the globe. It's very mild. And I look at this rendered image on this, coming up, insert this rendered image. I rotate around the z-axis, increase my angle, rotate around the y-axis, and I see sort of a very minor degree. In terms of getting the echoes out of view, the magic cut, take these echoes out. And you can see that there's a mild degree under light, a mild degree of micronative. In terms of getting the other echoes out of view, again, I'm just going to leave as well. Again, when you're using the edit light function on the baby, remember that that angle is getting the light around from 2 o'clock over to 11 o'clock. I'll save that image to dry. I'm going to do one more volume just to try and get a better position. But as I look at that now, I can see that there's a mild degree of micronation. I want to spend time just looking at this in the 2D as well. I want to see the nasal bone. I want to see the normal nasal bone. Again, you can see a mild degree of micronative, which is a real finding. And if we come back to looking at the corpus callosum, we'll come back. Oh, yeah. Okay. Are there any questions from the audience? With part of the examination, it's important to check the rest of the